Hi everyone. Today we'll explore an important topic that blends medical science with cultural and spiritual practice, and that is diabetes management during the holy month of Ramadan. In this talk, we'll break down the management algorithm, discuss risk stratification, and highlight practical adjustment in medication, lifestyle, and patient education to support safe fasting. So, as an introduction, fasting, the holy month of Ramadan, constitute one of the five pillars of Muslim faith, and that is prayer, charity, fasting, and pilgrimage. Illness such as diabetes constitute an exemption from fasting. However, majority of Muslims with diabetes do not consider themselves unwell and choose to fast. This should be respected, and such patients should be supported to help them fast safely. So, if the patient would practice fasting during Ramadan, a pre-counseling and clinical assessment is essential component of managing patient with diabetes during Ramadan. And one important thing is to assess, among others, is the presence of comorbidities and with risk stratification as listed here. For example, for a very high risk patient and for them fasting is not recommended, the clinical features are as follows: severe hyperglycemia, a history of recurrent hypoglycemia, presence of recent hyperglycemic crisis. And for high risk patient, the clinical features listed here are moderate hyperglycemia, significant vascular complication, patient living alone with comorbid conditions, and an elderly patient, and they may choose not to fast. Okay, so for moderate risk patients, these patients that are more stable in the sense that patients A1C may be less than 8% on lifestyle intervention, maybe on oral medication, but sometimes uh, with short-acting insulin, and then they may choose to fast, but with caution. Now, for low-risk patients, these are patients with considered good glucose control with medication that are not at risk for hypoglycemia. They may choose to fast. So, whatever decision the patient may have, even they are at risk, we need to help them manage their fast safely. Okay, there is one guideline on how to go about with the glucose lowering medication used before and during Ramadan. As you can see, the upper tier are the usual ADA-ESD recommendation in the people with diabetes not on fasting during Ramadan. And this is the usual recommendation by ADA-ESD. The second tier is the recommendation for Ramadan, just in case they are already chosen their medication based on the general guideline. However, during Ramadan, it should allow flexibility in glycemic target to minimize risk of acute complication, including hypoglycemia during Ramadan. Assuming they have started and chosen a medications based on usual guidelines. For example, if they choose GLP-1 receptor agonist, the recommendation is to ensure patient on a stable tolerated dose at start of Ramadan. If the patient is using SGLT2 inhibitor, continue usual dose during Ramadan with advice on hydration. For patient who already receiving TCD and DPP4 inhibitor, no change to usual dose. No, do not use DPP4, however, when you start with GLP-1 receptor agonist. For SU, consider stopping or reducing dose if appropriate to prevent hypoglycemia. And in people with basal insulin or on people on basal insulin, consider stopping or reducing dose if appropriate, again to prevent hypoglycemia. Now, another recommended medical therapy changes during Ramadan for patients with type 2 diabetes. This is with oral agent and GLP-1 receptor agonists prior to or before Ramadan and during Ramadan. For metformin, since it is not associated with hypoglycemia, no change in total daily dose. If it's once a day, usual dose at iftar meal, twice a day of metformin, usual dose at iftar and suhoor meal. If it's 3 times a day, consider the lunchtime dose with iftar meal and take the morning dose at suhoor. If the patient is receiving a slow release formulation of metformin, take it at iftar. Okay. So for SGLT2 inhibitor, no dose change is usually required, but patients should be well established on this prior to start of Ramadan. Ensure adequate hydration is very important. It is not recommended starting it as a new medication immediately prior or to or during Ramadan. Okay, for GLP-1 receptor agonist, no dose change is usually required, but patients should be established on a stable, tolerated dose a few weeks prior to start of Ramadan. If not tolerated, either reduce the dose or stop the GLP-1 receptor agonist, especially with GI symptoms. DPP-4 inhibitors, no dose change is usually required, but considered reducing the dose of concomitant SU or stopping SU. TCD, no dose change, taken with either iftar or suhoor, preferably with a larger meal, but it will take 10 to 12 weeks for maximal effect. Therefore, consider starting a few weeks prior to start of Ramadan. Reduce the dose to stop SU if concomitantly used. SU considered either substituting, stopping, or reducing the dose to prevent hypoglycemia. If SU once a day, take the usual dose at iftar meal. If it's twice a day, usual dose at iftar meal and 50% of the usual dose with suhoor meal. Okay, managing injectable therapy before and during Ramadan. Now, if you can see the initiation and titration before Ramadan, this is the usual thing that we do. However, during Ramadan, in patient on GLP-1 receptor agonist, consider stopping or reducing the dose if the patient experiencing GI symptoms. If on basal insulin, the recommendation is take with iftar meal, consider 20% reduction if twice a day, switch morning dose to iftar meal, and take the 50% of the evening dose with suhoor meal. If on prandial insulin, the recommendation is to take the usual morning dose with iftar meal, skip lunchtime dose, and take 50% evening dose with suhoor meal. For people receiving premix, consider switching premix to basal insulin due to higher hypoglycemia risk. If patient continues with it, take usual morning dose with iftar meal and 50% of the usual evening dose for suhoor meal, and need to skip lunchtime dose if on 3 times a day regimen. And another recommended changes for insulin therapy for patients with type 2 diabetes during Ramadan. If the patient is taking insulin at the same time as you, consider stopping SU. For any insulin, try to titrate and establish dose to achieve adequate glycemic control prior to start of Ramadan, and then adjust dose during Ramadan accordingly. For basal insulin once a day, take with iftar meal, but consider a 20% reduction from usual dose. If it's twice a day basal insulin, take the usual morning dose with iftar meal and 50% of the usual evening dose for suhoor meal. For rapid-acting analog, take the usual morning dose with iftar meal, skip the usual lunchtime dose, and take 50% of the usual evening dose for suhoor meal if required. And if the patient is using premixed insulin, take the usual morning dose with iftar meal and 50% of the usual evening dose for suhoor meal. Skip the usual lunchtime dose if on 3 times a day regimen. Now, this is the algorithm for premixed insulin titration during Ramadan. Now, you have to monitor the blood sugar of the patient. You have to ask the patient to monitor. If the monitor blood sugar is more than 300, you need to ask the patient to break the fast for fear that this patient may have hyperglycemic crisis. Okay? So you need to increase daily insulin dose by 20%. If the monitor blood sugar is more than 180, you need to increase insulin daily dose by 10%, but you may continue with the fasting. Okay? If the range of blood sugar is 100 to 180, no change. If the blood sugar is less than 70, you need to break the fast and you need to reduce insulin daily dose by 20%. And if the blood sugar is less than 50, again, you need to break the fast, stop insulin, or reduce insulin daily dose by this time 30 to 40%. So this is the last slide. However, this slide looks a bit crowded, but let me break it down into simpler terms. It shows the management algorithm for people with type 2 diabetes who plan to fast during Ramadan. Ideally, 1 to 2 months before Ramadan, patients should undergo a medical assessment with a physician or diabetes nurse. Next step is risk stratification. Low risk patient, that is well-controlled diabetes with A1C less than 7% on safe medications, fasting is generally allowed. With moderate risk, A1C of less than 8% may be on short-acting agent, now fasting possible but with caution. In high-risk patient with A1C 8 to 10%, elderly, or with comorbidities, fasting may not be recommended. A very high-risk patient, severe hyper or even hypoglycemia, type 1 diabetes, and pregnancy, dialysis, fasting is contraindicated. In terms of medication, adjustments are important. Like for example, oral agents adjust metformin schedule, reduce sulfonylureas, and avoid SGLT2 inhibitor. With insulin, we need to modify timing and dose, consider long-acting at night and rapid-acting with meals. During Ramadan, focus on education is essential. Emphasize meal planning, hydration, physical activity, and regular glucose monitoring. Stop fasting if glucose falls 70 and below or rises to equal and above 250 to 300 milligrams per deciliter. After Ramadan, return to the pre-Ramadan regimen and watch out closely for hyperglycemia, especially during celebration. So that's the end of our short presentation.